Welcome everyone to the Emedica GP update. This is session 4 and we're covering obesity today. So for those that haven't met me before, my name is Muhibbur Rahman. I'm a portfolio GP, which means I've got multiple roles. My clinical roles including being a partner in a private practice, working as a locum in various NHS practices and covering 2 different community detox clinics. Most of my time now though is spent in medical education. So I'm a consultant in medical education and the medical director of Emedica. I'm an author. I've written on GP careers, various study guides for MRCGP, AKT, CSA, RCA, and now SCA. I sit on the NICE GP reference panel, and our team at Emedica now, this is our 20th year, and we've trained over 83,000 delegates. So what we're going to do today, each one of these GP updates focus on one clinical topic. So today we're going to focus on the new updated obesity guidelines. So we'll look at some of the key theory behind the guideline. To keep it interactive, we'll base the learning around questions so that if you're sitting MRCGP exams, that will get you into exam mode and help you prepare. If you're already qualified or if you're not sitting the exams but just want to improve your knowledge, it just helps it hopefully keep it a bit more interactive. And then we'll finish with a couple of simple practical consulting tips related to this topic, and there's a Q&A at the end. Okay, so the NICE guideline on weight and obesity was updated in January 2025. So it's NG246 if you want to look up the full guideline. And we're going to try to learn some of the key parts within that guideline that will help you both for exams and for everyday consulting. So try to keep it interactive. So, use the discussion, the comments to get involved in the discussion. When we do the questions, after I've given you some time to look at it, I'll launch a poll. Use the poll to answer the questions. If you've got a question for myself or the faculty, use the Q&A for that. Because there's so many people, when other people say things in the chat disappears, but it will stay in the Q&A until it's been dealt with. Okay. So we're going to go straight into a question. So have a look at the question. I'll launch a poll and we'll do the theory afterwards. Okay, here we go. Okay, well done. So every single answer has been picked. The most popular answer is the correct one. So the correct answer is B. 0.44 is this patient's waist to height ratio. Okay, so first thing is to calculate the waist to height ratio. All we need is what is their waist circumference and what is their height in the same units. Now, in this case, the height and the waist circumference are both given in centimeters already, so we don't need to do any conversions. Okay, the weight and the body mass index for the calculation of this isn't relevant, but it can be relevant for the interpretation because we want to use this to look at the patient's overall risk. Okay, so in terms of the calculation, what is the waist circumference in centimeters? And you divide that by the height in centimeters. So the waist circumference is 80, the height is 180. If you do 80 divided by 180, that gives you 0.44. Okay. Now, I'm going to show you a slightly different question. Same topic, but a lot of patients in the UK, they will describe their height in feet and inches rather than centimeters. That's how most people in the UK talk about their height. Similarly, a lot of people will say, my waist is this many inches rather than centimeters. So let's have a look at that. Okay, so there's an extra step here because we've got to convert feet and inches into just inches. Good thing is the waist circumference already inches. Okay, so a patient who's 5'6", 1 foot is 12 inches, right? So first thing is to do 5 times 12, that's 60 inches, that's the 5 feet. Add the 6 inches, because they're 5'6". That's 66 inches is their height. And the waist circumference is 33 inches, so it's 33 divided by 66, which is 0.5. Okay, so waist to height ratio. This is one of the measures in the new guidelines. In the older guidelines, we used to just focus on waist circumference on its own rather than the ratio, which is actually a better indicator of risk. So this is for use for adults whose body mass index is under 35, because once they're 35 plus and they're into obesity too, they're at significantly increased risk regardless of the waist circumference and the waist to height ratio. So what you do is you measure the waist circumference, measure the height, use the same units for both. So you can use centimeters for both or inches for both, doesn't matter. And then all you do, waist to height ratio. Ratio always means divide. So just divide the waist circumference, then divided by the height. In terms of interpreting the outcome, 0.4 up to 0.49 is within the healthy range. 0.5 to 0.59 suggests they've got increased central adiposity and increased risk. And 0.6 or more is high central adiposity with significantly increased risk. Okay, so let's look at interpreting the overall picture. Have a look at this question. Now, this is a much more challenging question, okay, because we're actually testing more than just the interpretation of the number, but also the broader picture, okay? And this is one of the things for those of you that are going to sit the MRCGP AKT, for example, that some of the high challenge questions, there may be some really important keywords that if you spot them or don't spot them could make a difference, even if you've got a broad knowledge of the overall topic. So two really important things here. The first is that this patient is of South Asian heritage. Okay. Now you see the body mass index of 24, in and of itself, if the patient wasn't South Asian, then this wouldn't be something that we'd be worried about. It's still within the healthy range, isn't it? Okay. And then we've got the waist to height ratio. Now, you already learned how to calculate that. So you can do 90 divided by 160 to get the waist to height ratio. That's 0.56. So we talked about that. That suggests increased central adiposity, increased risk. Now, at what category does this BMI place this patient? Are they in the healthy range, overweight, obesity 1, obesity 2, or obesity 3? That's the broader thing that's being tested here, right? Now, if you read all the numbers, knew how to do the calculation, but missed this bit, then you might think, okay, that's a healthy weight. They have got slightly increased central adiposity, so there is some increased risk there. And that's actually what happened. The most popular answer, most of you picked C, healthy weight with central adiposity, increased risk. But the correct answer is actually F. This patient is classified as overweight. And that's because he's from one of the ethnicities that the guideline specifically mentions are known to have increased risk. Okay, mostly that's genetic, but there are other factors. So South Asian is one of those. And for those, the thresholds actually, when we classify someone as overweight, obese, obesity 2, obesity 3, they drop. Okay, so this patient is actually in the overweight range. Okay, he's not quite obese. Anyone know the threshold where obesity 1 kicks in for a patient of South Asian heritage? Type into the chat. Obesity 1 kicks in at 27.5. It's 2.5 reduced compared to normal, because most patients, it'd be 30, wouldn't it? So you take 2.5 away from that. So they're not obese yet, but they are overweight. They have got central adiposity because this is raised, okay? It's above 0.5, but it's not 0.6. So they have got increased risk. That's why the correct answer is F. It's a very high challenge question because lots of steps there, and then just picking up the fact that they're South Asian and having that knowledge. So if we recap the guideline, this is taken from one of our clinical case cards, okay? So sort of quick way to rapidly review lots of different guidelines. So, first of all, to calculate someone's body mass index, you take their weight in kilograms and you divide it by their height in meters squared. And then the thresholds below 18.5 is considered underweight. 18.5 up to 24.9 is considered within the healthy range. 25 for most patients is where overweight kicks in. Obesity 1 at 30, obesity 2 at 35, obesity 3 at 40. But patients which are specifically in groups that the NICE guideline mentions have increased risk. So that includes South Asian, Chinese, other Asian, Middle Eastern, Black African, African Caribbean family heritage. All of these groups, the threshold for overweight starts at 23 and goes to 27.4. 27.5 is when obesity 1 kicks in. And then basically for obesity 1, 2, and 3, you drop the threshold by 2.5. So rather than being 30, 35, 40, it's 27.5, 32.5, 37.5. Okay. And then the waist to height ratio really looked at. Now, this is important because you see, if someone is in the overweight category, then if they've got a healthy waist to height ratio, i.e., there's no significantly increased risk based on that, and they're just overweight rather than obese, then we could just give them some sort of standardized advice on healthy eating, what makes a healthy diet, doing regular exercise, those kinds of things. All right. Once you've got increased risk, so someone's waist to height ratio is 0.5 and above, they've got increased risk, all right? Then we want to go beyond that and build on that general advice and have more specific behavioral interventions. Maybe ask them to keep a diet record of their diet, a diary of their food, maybe for a few weeks, come back, go through it, give them suggestions for specific things they can cut out rather than general healthy eating. They might benefit from seeing a dietitian to help them come up with a plan that they can manage, looking at their specific diet. Obesity 1, once they've made lifestyle and diet changes and lost some weight, then they may also benefit from medication. Okay. Obesity 2 and obesity 3, these patients, again, may benefit from medication, but if they've got additional risk factors, they may also benefit from bariatric surgery. So we might refer on for that. Now, within that, what we can prescribe in general practice, what would need to refer for it to be prescribed in secondary care, has recently changed. That's one of the things that was updated in the guidelines. So let's look at that in a bit more detail. We're going to do a set of 3 questions. Okay. Here's the first one. Okay, so we'll start you off with a fairly straightforward one. Okay, so you can see this patient, body mass index of 32 puts him into obesity 1. Waist height ratio is 0.5, so that is increased risk. And you can see they've made some changes and, diet and exercise, and they've lost some weight because it says have minimal success. That suggests that they've lost some weight. Okay. So What could we do? Well, we could prescribe orlistat for this patient. Their body mass index isn't at the threshold where they're eligible for the injectables under the NHS. Okay. But we could prescribe orlistat, and we can prescribe that in primary care, can't we? Okay. Let's look at the second one. Okay, great. I'll stop you there. Very interesting. So there's a big spread of answers. This is more challenging than the one that we've just done. So the three popular answers are B, orlistat, F, tirzepatide, and G, refer to secondary care for specialist assessment. Okay. For example, you might refer to a specific weight management service. Okay. So that's the main spread. And then a few people have picked C, prescribe liraglutide. Now, for those of you sitting MRCGP, it's important to remember that this is a GP exam. So if the question says like this, prescribe, it means that you're prescribing it. Whereas, for example, there are some things that someone might meet the threshold for prescribing, but if it needs to be prescribed in secondary care, then the right answer wouldn't be for us to prescribe it. It would fall under G. Okay. The correct answer here, though, is B, prescribe orlistat. All right. Now, two things about this. So one is there's, the knowledge side of the guideline. So what's the threshold for prescribing orlistat? Anyone know what the default threshold is in terms of body mass index? Type into the chat. 30 plus. So how come we can prescribe it in this patient? Because in patients with additional risk factors, the threshold is 28 plus. Okay. I can see they've got hypertension. Similarly, if you had a patient with diabetes and they've got an additional risk factor, then the threshold drops. So it's 28 and above. And then the other thing is a bit about technique. Let me know in the chat, is there anyone that thought it was orlistat, but then didn't want to put B because the answer to the last one was B? And they thought, either you thought you can't use the same option more than once, which in a set of extended matching questions, you can use the same option once, more than once, or not at all. Or you thought, well, although you can use the same one more than once, they wouldn't put two in a row with the same answer. And so, although this is what fit and you were drawn to it, that was your first instinct, you actively changed your mind because you thought, oh, they're trying to get me. They wouldn't put two in a row, and you changed it from B to one of the others. Yeah, so more than one person has done that in most cases, okay? That's a really important thing. So I call the EMQ trap. Treat each question in a set as a separate question. Just pick the answer that fits. But the other thing is, if you are naturally drawn to something, there's a reason you're naturally drawn to it. You either might have read it, and while you don't think you remember, subconsciously your mind remembers, or you might have actually seen a patient. I had a patient like this, and I remember, oh yeah, because I had additional risk factor, we could start it even though they weren't 30. I actually prescribe them this, and you remember it. Okay. So the correct answer is B. Right, third one in the set. Good. So the spread of answers, the three most popular answers are A, repeat the advice and review. F, prescribe tirzepatide. Mounjaro is the brand name for that. And then the most popular, G, refer to secondary care. The correct answer here is G. So well done. That was the most popular answer. About half of you picked that. So about half picked one of the other options. So let's look at why this patient should be referred to secondary care. Well, if you have a look, they've already tried orlistat and they've lost some weight, but only 2%. All right. That's in 3 months. Their body mass index is still 31. So it's still in obesity 1. So they're still at increased risk. And you can see they're, sort of stuck on this. They're not losing any further weight. They would benefit from losing more to get to a healthy weight range. They're still obese and so for at increased risk, right? Okay. So the reason the correct answer is G is that this patient, if they're going to be considered for some of the other options, for example, Saxenda, this level would be within the license for that. That's something that will be prescribed in secondary care. Okay. Tirzepatide, we can prescribe in primary care, but they don't meet the sort of nice guidelines for the prescribing threshold for that. We'll look at that in a minute. Okay, we'll look at all of the main drugs and what the indications are in the guideline. That brings me on to something else that's really important, and that is that sometimes what you'll see is that there might be local formulary or local funding available for certain medications, and that can vary from one area to the other. The answer in the exam isn't going to be based on that because they don't know where you're training. They don't know what the different regional variations are in that situation. They're going to base it on if there's a nationally published guidance, like NICE guideline, what does the guideline say? Okay. So that's why the correct answer is G, is that this patient doesn't fulfill the criteria for us to prescribe tirzepatide. Liraglutide, Saxenda, while it's within the license, that's not something we can prescribe in primary care. It's a secondary care specialist obesity service in the NICE guideline. Okay. So let's look at drugs treatment generally. Then we'll look at the newer injectables and I'll look at each medication in a bit more depth, especially if you're seeing patients. And because this has been in the news because of the bigger launch this week, expect over the next few weeks, you're going to see a lot of patients coming to see you, especially those that maybe have been paying a lot of money to have it done privately. And now they have heard, they might not know the finer details. They've just heard injectables are now available in GP. Go and see your GP. That's what they've heard. Okay. So first of all, we wouldn't consider any drug treatment options until someone's started making changes to their diet, started doing some exercise, and we've sort of evaluated that they are keeping to that. Now, if they've done that and they've not reached their target weight or they've reached a plateau and they're still at risk, that's when we could start thinking about drug treatment. So in primary care, up until the new launch, really the only option we had was orlistat. And so that's 30 plus body mass index, even if they've got no other risk factors, or if they've got other risk factors, then the threshold is lower, 28, like hypertension, like diabetes. Okay. Liraglutide, brand name Saxenda. The BNF license for this is 30 plus with no other risk factors, 27 plus with other risk factors. But in the NICE guideline from 2021 and in the 2025 guideline, this hasn't changed. It's stayed the same as what the 2021 guideline said, is that for it to be prescribed within the NHS, it can only be started by a specialist obesity service. And even then, only for those that fulfill the criteria for obesity 2. So body mass index 35 plus for most patients or 32.5 plus for those ethnicities with known higher risk. So you couldn't give it to someone at obesity 1. And if you thought that they might benefit from it, like our last patient, you see, this patient's at 31, okay, then they could be considered for this according to the license, but for them to get it on the NHS, they need to be 35 plus, okay? And then the new injectables. So we've got semaglutide. They need to have at least one weight-related comorbidity, and then either a body mass index of 35 or more, i.e. obesity 2, or between 30 and 34.9, and they meet the criteria for referral to a specialist obesity services. Okay, often that would be higher risk patients, multiple morbidities. Tirzepatide, this is the Mounjaro, okay? This is the one that now we can prescribe in GP. It's the big change, right? So there's a difference between what the NICE guideline says, which is they need to have a body mass index that puts them into obesity 2 and at least one weight-related comorbidity. Whereas what a lot of ICBs are funding in England for the first year of the launch is body mass index of 40 plus and 4 weight-related comorbidities, i.e. they're really narrowly restricting it. Now that bit isn't widely understood by the general public. So what you're going to see is lots of people turning up asking for this just because they've heard about it and they've heard the name. Okay, so let's look at that. Type into the chat when they say at least one weight-related comorbidity. What are the weight-related comorbidities we're talking about? What does the NICE guideline classify as a weight-related comorbidity? So I've mentioned a couple already. Hypertension I mentioned, type 2 diabetes I mentioned. What else? Type into the chat. Okay, well done. Yes, between you, you've got them all. Okay, so hypertension, dyslipidemia, any form of established cardiovascular disease, type 2 diabetes, but also pre-diabetes now, and then obstructive sleep apnea. Okay, so just to recap the details of the prescribing, orlistat, which we've been able to prescribe in primary care for a long time. They've tried diet and exercise, still at risk, 30 plus with no other risk factors, or 28 plus with other risk factors. Okay. This can not only be prescribed by primary care, but it can actually also be prescribed by prescribing pharmacists. Okay. And the dose is 120 milligrams, generally given 3 times a day with meals, basically. They'd have it for 12 weeks. If they don't lose at least 5% of their starting weight, it will generally be discontinued. And it's important that because of the way it works, it's going to be effective if they're taking it with a main meal that contains fats in it. If they're having a meal that has no fat in it, it's not going to be effective. Tirzepatide, so brand name Mounjaro. So the NICE guideline allows for this to be prescribed with a body mass index of 35 plus and at least one weight-related comorbidity. As I mentioned, what's being funded in England particularly is for the first year of the launch, 40 plus body mass index and 4 weight-related comorbidities. Remember that the threshold for obesity 2, which is what this set at, drops by 2.5 for those ethnicities known to be at increased risk. Okay. And the nice thing about tirzepatide compared to Saxenda, liraglutide is daily. This one, at least the injection's only once a week. So it's 2.5 milligrams for 4 weeks. And then they can titrate up. So then go to 5, then go to 7.5, up until the maximum is 15 milligrams. And if they haven't lost 5% of their starting weight after 6 months at the top dose, so it takes some time to titrate to top dose, then you keep them on that for 6 months, then you see have they lost at least 5, then you think about stopping it. So liraglutide, Saxenda, I mentioned the BNF threshold. Remember the NICE guideline is body mass index of 35 plus, and then they've got non-diabetic hypoglycemia and raised cardiovascular risk. Lower threshold for those at-risk ethnicities, but it can only be prescribed in secondary care. This is a daily injection. Again, if they haven't lost 5%, that's common across the board, is that 5% of the starting weight is what we're looking at. This one, though, is at 12 weeks. Semaglutide, so Wegovy is the brand name. So it's 35 plus with a weight-related comorbidity, or 30 plus, and they're eligible for specialist referral. This is only secondary care in terms of license. This is a once weekly injection, starts at 0.25, and maximum dosage goes up to 2.4. Again, it's 5%, but that's at 6 months. Okay, if they've not lost 5% of their starting weight. Okay, great. So that's covering the sort of main medications. And also we've looked at waist to height ratio. We've looked at how to calculate that, how to use that in the context of is the patient overweight, obese, obesity 1, 2, 3, and so on. Okay, so hopefully you've got a much better idea of that, especially as this is going to be, I suspect, over the next few weeks, something that you're going to see a lot of patients coming to ask you about because it's been in the papers, it's been on social media. So let's move on to the next part where I want to talk a little bit about some practical consulting tips, and then we'll allow some time for Q&A. So one of the big things is, you know, both in terms of everyday consulting and actually being able to help our patients, but especially if you get a case related to this in the SCA, for example, is so important to think about empathy and sensitivity in relation to this alongside your clinical knowledge. One of the things is we all need to reflect on our own biases that we have around weight. So it's important that we avoid diagnostic overshadowing, that, there can be things that we might, someone might have other illnesses, they might have other things that they're at risk at, and our own biases can sometimes get in the way of that. Similarly, have they had prior healthcare trauma? Have they had a bad experience in the past when they've tried to get help in relation to this? So one of the things that the guideline recommends is that as part of being sensitive to how the patient might feel about this, especially if they have come for something else and you pick up that, they're obese, overweight, and at risk because of maybe a higher central adiposity, that before you go to specifically discuss the weight, that you seek permission, and that in the language that we use, that we should use non-stigmatizing language. So they're sort of two of the things I want to have a little practice on. And the other thing is that, it takes a lot of courage for someone to come and seek help. Often before they've come to us to seek help, they've tried themselves many times. And so it's really important to, commend that. Well done on coming to get help. It's not easy to lose weight on your own. Lots of patients struggle. I mentioned earlier, one of my portfolio roles, I cover two different community detox units. So we detox people who, have got significant alcohol dependence, or they might be dependent on heroin or cocaine. And, one of the things, again, in a similar way, that we have to really show them empathy, be sensitive in our language, highlight that, it takes a lot of courage for someone to come to book themselves in for a detox. And that it's not easy. There's lots of patients who try on their own. There's lots of patients that go through detox. They stay off for a long time, but then something happens and then they might relapse. But again, to highlight that they can then, you've done it once, you can give up again. And well done for trying, well done for coming. And also that it can be really frustrating when someone's tried lots of things. They've tried different diets, they've tried exercising, and sometimes there can be different things that get in the way. Okay. So I'll be the patient. Okay. And what I'm going to do is I'm going to sort of ask for a volunteer to have a go at maybe just how might you seek permission? How might you get into that discussion about weight? Okay. Especially if someone didn't present, if someone comes specifically and says, I want help to lose weight, the fact that they've presented it that, you've still got to have empathy and sensitivity, you've still got to use non-stigmatizing language. But in a way, they've said that that's their presenting complaint. That gives you a tacit, if you like, they've given you a sort of permission to discuss this. What if someone came for something else? Okay. So can I have a volunteer, someone that'd like to have a go? We'll do it as a telephone consult, so you can just turn on your mic. You won't have to turn your camera on. So I can see someone's got their hand up. Okay, great. So Dr. Azmat Kobakhidze, I think it is. I hope I've said that correctly. If you unmute your microphone and just introduce yourself so everyone can hear.
Oh, hello. Hello, hiya.
Hi, just introduce yourself. Tell us your name, where you're joining us from today.
So I'm joining from Scroll. I'm ST3.
Okay, fantastic. So have you done your SCA already, or are you going to be doing it soon?
I got it booked in September, but I did pass AKT, and I want to thank you for that, for your support.
No, you're welcome, and it's lovely to see you on here, and thank you for joining. Okay, great. So, Asmat, I'll be the patient, okay, and we'll just start the consultation off, and all you know about me, that I've booked a telephone consult, and I haven't got any. I don't come to the GP very often. You can't see any medication on my record, no allergies. There's no significant past medical history noted. Okay. Hi, Doctor. It's Mohib here. Thanks for agreeing to this telephone consultation.
Hi, this is Dr. Asmat. How can I help you today?
Doc, I've noticed that my knees are really, really painful, and it's just getting in the way of things that I'd like to do.
Okay, tell me more about it, please.
Well, like I used to really enjoy walking, but because different things happened, I changed my job from one that was quite physical to one where I'm sitting down on a computer for most of the day. And
Okay.
so I didn't have as much time, but I think over time that just being sat in a chair a lot has had an impact on me in different ways. And now it's got to the point that when I do try to walk,
Yes.
my knees just hurt too much. And so like it's stopping me exercising really.
Okay. Um, that must be very hard, and it is affecting you. I can see you mentioned that you can't exercise anymore. Um, tell me, is it okay if I go through some questions just to for me to understand, you know, um,
Of
better?
course, of course,
Yeah.
doctor, that's why I've booked in.
So how long do you notice this pain now?
I'd say probably about 6 months now.
Okay. Yeah. Is it every day this pain ongoing or?
Yeah, I
Yeah.
have like a grumbling pain, but
Mm.
if I try to do anything active, then
Yes.
like the more I do it, like if I do try to walk, I might walk 10, 15 minutes, and it's definitely worse the more I
Yes.
walk.
And can you tell me in the morning do you get this pain or any particular time of the day?
No, I think, in the morning, because I've not done anything with it, it's okay. But it's like, like after I start walking, or
Yeah.
if I do anything strenuous, then
Okay.
it gets really bad.
Okay. Do you get morning stiffness? I just
N-
want to check
No,
that. No.
no, I wouldn't say so. In the morning, it's okay because, I've just been in bed. But, like it, if I do try to walk, the more I walk, the worse
Yeah.
it.
And anything makes it better, have you noticed?
Well, I try not to take painkillers, but if it's really bad, then I take some painkillers. It does help. But I'm not the kind of person that really likes tablets.
Okay. So, and so far you just tried the painkillers, simple painkillers.
Yeah, just like I only take paracetamol really.
Okay. How often do you take it?
Just
Regularly or?
no, if it's really bad, and then I might take two. I would say that I would rarely take more than one dose in a day, and
Okay.
most days I don't even take it. I just put up with it.
Okay. Um, so, what do you think? Today you are coming. Was there any particular, treatment on your mind we could have offered or?
Really, I mean, I just want to know, like, why am I getting it really? And what would be great is if I could walk, I think it would help me in other ways as well.
Yes, sure. And was there any particular tests or scans we could do?
Well,
Anything particular you're thinking?
well, I mean, if you think that a scan would help you find out what's causing it, yeah. I
Okay.
just want to know what it is and
Yeah.
fix it, really. That's the main thing.
And can I ask regarding your exercise, how much exercise do you do and how often?
Yeah, so to be honest, not very much now. As I mentioned, I used to have an active job. Probably about 5 years ago, I
Yes,
changed to a desk-based job. So I just sit on the computer, and to be
yes,
honest, it's also quite pressured. It's quite stressful. So I think
sure.
because of that, I'm often eating at my desk. I think
Yeah,
over time, that's had an impact on me. And
yeah,
so now, then I can't do as much exercise. I used to go for, not only was I active before in my lunch break, I'd go for a nice walk, and then I'd, bring a packed lunch from home. I'd
sure.
eat more healthily, but I'd also, you know, enjoy that time, get out in the fresh air. do some walking, and I used to play sports, but now I can't even walk for long distance.
Yeah,
Never mind play sports.
that must be very difficult. Um, Another question is, can I ask about your weight? Do you think you gained weight lately, or how do you think about?
Definitely, definitely,
Yeah.
doctor. I think, moving from being active to sitting at my desk all day, I've got one of those step counters. I
Yes.
used to hit more than 10,000 steps every single day. Actually, a lot of days it'd be 15 plus. I'm
Yes.
lucky if I hit 2,000 now. And
Yeah.
then, as I mentioned,
Yeah.
I think I definitely do stress eat
Sure.
because the job's quite pressured.
Yeah. And you mentioned that you take packed lunch. But is it you cook at home from scratch, or
I used to do that, doctor, but not really now. So I often have snacks. I'm
okay?
working odd shifts. And so
Yeah.
what will happen is on the way home, I'll just grab a takeout, maybe like a burger and chips, or
Yes.
sometimes we'll order, like as an office, we'll order something in
Sure.
for lunch. And so
Yeah.
that just so that we can all eat at our desk because we haven't got time to go out.
Sure.
And so, yeah, my diet's not great.
Okay. We can address that. And another question regarding your alcohol intake. Do you drink at all alcohol?
I don't drink.
Okay. And smoking?
Sometimes if it's been really stressful, then we don't get many breaks anyway. But if
Mhm.
we might go out the back and have a couple, but
Sure.
only really like at work and when it's stressful.
And how many a day, roughly?
Maybe three or four.
Okay. All right. And do you take any medications regularly?
Okay. I'm going to stop you there. Thank you very much. We've just really wanted to highlight
Yes.
sort of how you might bring in and how weight can present as an issue that actually might not be what someone presents with. And you've done a good job there of uh, sort of bringing it in a sensitive way. I'm going to talk about some of the phrases, some of the things that we can use to make that even better. So well done. Thank you very much for volunteering.
No problem.
Here's some phrases that you might find helpful if you think that weight could be an issue, but it's not what they came for. Because I mentioned, if someone sort of come specifically to ask for help with weight, then it's much easier, right? You can just start asking some of those questions. But if, for example, and like joint pains and the way that it was described, and there were some cues there about that, the sedentary lifestyle, and I used to be more active, and so on, then one of the ways that you might just seek that permission that, would it be okay if we talked about your weight and how it might relate to your health? Or, like you said, do you think that your weight might have changed? And you can bring that in then that look, well, weight can be one of the factors that can affect conditions like joint pain. And if you've put on weight over time, that does put more pressure on the joint, and that can lead to the fact that you're getting pains, which might mean then you exercise less, which then contributes to the weight being further increased because you're being less active. Other things that it can affect, it can affect your blood pressure. It can increase your chance of diabetes. Would it be helpful if we explore this in a bit more detail today? Okay. Um, Similarly, if we think about non-stigmatizing language, some of the things that you might think that could be quite useful is things like broadening it out and then making it specific to the patient. That look, people living with increased weight or with a higher weight can experience things like fatigue or breathlessness. Are these symptoms that affect you? So broaden it and then bring it down to them. Or, let's say you've checked someone's height and weight and you've got their body mass index and it's raised. That look, for any given height, there's a range of weight that's healthy. Now, at the moment, your weight is above the range that's associated with the lowest health risk. So it's higher than what would be considered a healthy range. Now, that can lead to, and then you can lead back to some of these things. It can lead to things like putting more pressure on your joints. It can increase blood pressure. It can increase your risk of diabetes. Is that something that would be helpful to explore? Okay. Right. Okay. So, and then just really to wrap up, I just want to talk about some additional resources. So that the BMA has just this month brought out a specific focus on tirzepatide because of the fact that there's this national rollout. Okay. Um, Public Health England has got this guide, Let's Talk About Weight, which talks about, specifically aimed for healthcare professionals, that some of the ways that we can do that. And then NICE has a quite nice sort of pictorial like this, where it's got these 1, 2, 3, 4, some of the things that you could think about in terms of empathy, sensitivity, alongside principles of care. So you can use some of this stuff alongside the knowledge base of what are the thresholds for risk, what are the thresholds to actually prescribe different drugs, to hopefully help you day to day, but also help you for those of you sitting SCA, for example. And some of the questions we did earlier would help those of you sitting AKT. So let me summarize. I'm going to talk to you about some of the other events that we've got coming up, some that you can join for free, some of our paid courses if you're sitting MRCGP exams, and then we'll take questions. So just to highlight that obesity is a major determinant of health. It is associated with increased risks of mood disorders, increased risk of diabetes, hypertension, cardiovascular disease, certain cancers, and so on. So if we can help our patients to get to a healthy weight, we can help in many other things beyond that, but it can also help their overall well-being, their self-confidence, their sort of self-image. And so things that will help good patient outcomes is sensitive discussion, use of non-stigmatizing language, bags of empathy and sensitivity, being aware of potential healthcare bias so you can counteract it, and then being knowledge-based, up to date with the evidence. So when medication might support a patient's journey to a healthier weight, we can prescribe it appropriately. So as of this week, Mounjaro is now available in primary care for a limited number of patients. It is still a black triangle drug. So what that means is, because it's new on the market, any side effect, even if it's minor, you should fill a yellow card, send it to the MHRA. Whereas most drugs, once they're established, the black triangle disappears in the BNF. What that means is, in that situation, we only use the yellow card if they have a significant side effect and have a major reaction, or go into anaphylaxis, or causes them to go into renal failure, or they end up in hospital. Do you see what I mean? But while it's got a back triangle next to it, it means that it's still relatively new, and even minor side effects should be reported. They're essentially still gathering the data to know what are the side effects that are less common, more common, rare, and so on. Okay. And that it's important for all of us to stay up to date, because as well as helping for those of you doing exams, many people on here today, did exams years ago. In fact, some of the names more than a decade ago. Okay, that it's going to help you for everyday consulting, and this right now is very topical. Right, there's going to be people coming to see you over the next few weeks. So just a highlight of some of our next few events. If we look at the next month, 2nd of July, we have our MRCGP SCA Essentials webinar. This is for doctors who are sitting the SCA any point in the next 12 months. Okay, that one's free to join. 3rd of July, we have our AKT Pass Guarantee program for those that are sitting the exam in October. 5th of July, for those that are not started training yet or are in ST1, we have a full day GPST Plus course. This course gives you sort of a clear plan of the different parts of MRCGP, useful courses to do during training so you can be more competitive when you qualify, how to get through training successfully, how to navigate the e-portfolio and all of your workplace-based assessment targets. What are the reasons that people get complaints? How can you avoid those? What are the things that might lead someone to have difficulties during training? If you know what they are, you can know how to avoid them. And then our Pass Guarantee program for the July exam, we've got the final webinar on the 8th. For those sitting AKT at some point in the next 12 months or so, on the 10th of July, we have our free AKT Essentials webinar. The SCA Essentials and AKT Essentials, we're running those jointly with MPS, so it's free to attend. Okay, and then our full day SCA intensive course is on the 30th July. So you get to see 20 role plays, you get detailed individual feedback and do a full mock case yourself. That's ideal for people sitting the SCA September, October, November. Okay, and then other MRCGP preparations courses we've got, as well as the SCA intensive, we've got a whole lot of AKT intensive. So we've got a full day AKT course at the end of August. We've got a half day stats course, half day admin course, start of September, and then a high yield clinical crammer 1 and 2 at 10th and 11th of September. Okay, and you can find out about all of the different things that we have on the Emedica website, emedica.co.uk. So just before we wrap up, and please do join the GP Training Support Facebook group. It's the largest group dedicated to GP training. Over 43,000 doctors in that group. If you'd like the recording, subscribe to our YouTube channel. That's our Facebook group. coming up to 44,000 members now. That's our YouTube channel. Okay. So any questions, put them in the Q&A. Someone's asked a really interesting question, that how do we support a woman who's obese, who's going through difficulty with fertility? Sometimes fertility clinic, might not want to accept them. One of the things is to, again, think about some of the things we talked about, that first of all, seek their permission to discuss the weight and highlight actually that there is evidence that if someone is obese, it can have a significant impact on fertility. If someone's overweight but not obese, there isn't an evidence that it impacts fertility. But if they are into obesity 1 or higher, and so that if we can talk to them about, first, just like anyone else, healthy eating, regular exercise, that if we can get them to a healthier weight, that in itself can improve their chances of having a successful pregnancy. Beyond that, things that we can do, well, if they are at that level and they're at risk, then once they've changed those things and managed to lose a little bit of weight, in GP, we can prescribe Orlistat. If they're significantly higher, we can, there's the option of tirzepatide now, which wasn't there before. Okay, if they fulfill the criteria for that. If they're not at that threshold, but if they're obese, that's when the increased impact on fertility happens, then they will fulfill the criteria for Orlistat. Do you see? So we could support them in that way. If beyond that, we still not able to, then, some of the other things that might help is a specific diet plan, referring them to a dietitian or a nutritionist. But these patients are very, very motivated. So if we can link getting to a healthier weight to increase chances of, successful pregnancy, that's a really great motivator. And you see a lot of patients, they'll make changes to their diet. They'll try all kinds of things. They'll be willing to put in the effort. And then once they've done that, we can support them with things like Orlistat, tirzepatide, and hopefully that can help them over time. Okay. I do hope you found it helpful. I hope you're a lot more confident now talking to patients about weight-related issues, that you're more confident in the drugs, which ones we can prescribe, what are the criteria for the ones we're going to refer to weight management service for them to be considered for prescribing in secondary care, and whether it's for your exams or for everyday consulting. I do hope it's been helpful. Do join us for the next one. Like anything in life, prepare and you will succeed.